So it's an absolute treat and pleasure to be here. Wish we were actually, of course, together in person, and I send warm regards from Los Angeles out to all of those attending the conference, as well as my colleagues. I know we will be together again soon. I'll go ahead and get started with that. And I think that this talk is a wonderful follow-up to what you just heard from Dr. Coleman in the last session. Perfect. Sorry, guys. I actually like your slide a lot better than this one. But as I was saying, I think that this talk will really be a nice follow-up on Dr. Coleman's. And we'll talk a bit about ovarian cancer genetics, both what it means to the survivor community, the previvors, and also for your families. This picture, and we see Runcie there as well as many of you, I hope, who are participating today, is probably from a few years ago when we could be together. And I just want us to remember why we're here, celebrating each other, celebrating life, and celebrating every day we have. And this is what I want us to look like next time we get together. We see lots of pieces of teal around that audience. And I just want this to be a sea of blue as we all celebrate life, celebrating survivorship and being together. I've been a gynecologic oncologist, believe it or not. Well, I shouldn't say believe it or not, but for over 30 years. And have been inspired and continue to be inspired by what I get to do and learn from the women I care for each day. But what I've realized more and more is that no matter what our discoveries in PARP inhibitors has been transformative, no matter what discoveries, the best thing, rather than just treating ovarian cancer, would be preventing ovarian cancer. And this quote from Ben Franklin is one that really resonates with me. And that's really the stage for today. I know many of you have already heard a good deal about genetics, but I am going to start off with some general comments to level the playing field. To remind you that when you think about genetic disease, cancer actually is the most common of all the genetic diseases. While the majority of cancers are associated with lifestyle, with what we call epigenetic changes, things that occur between gene-environment interactions. Again, for ovarian cancer, this is closer to 20%, but of all cancer diagnoses, 5 to 10% are due to an inherited alteration in one of our genes that lead us to collect additional alterations that lead the cell to become a cancer cell. Each year, there seem to be more and more hereditary cancer syndromes defined. Just this week, I saw 2 new papers defining new syndromes. So this is going to continue to grow. And as we look at our national guidelines, each year, the catchment of everyone who should be recommended to have testing also continues to increase because we have more and more treatments that would target those genes. To just give some more specifics, again, most cancers, as I said, are sporadic. They occur because of gene-environment interactions, but nonetheless, the cancer cell behavior is due to this accumulation of genetic changes that change how the cell acts. These changes accumulate in those tissues that allow these cells to not follow the usual pathways and allow them to invade other tissues and then spread. As we get older, we accumulate more and more of these changes, of course, and which is why cancer is considered a disease of aging in general. And there are some things we can do. Even if you have inherited one of these genes, there are environmental and lifestyle things you can do to try to reduce your risk or delay your risk of that cancer. With genetic cancers or hereditary cancers, there is a cancer that's passed down from generation to generation. The cancer-specific gene, like a BRCA gene, is in every single cell in that person's body, and the parent indeed has it in either the egg and or the sperm. And so when the embryo is formed, that embryo becoming a baby, a child, has that same gene in every cell of the body. So it sort of unfortunately gives them this head start. They have this cancer gene already, which sets up the situation where they can accumulate more and more genes more quickly, which is why hereditary cancers often happen at a younger age, because that clock on becoming a cancer cell starts even earlier. As I say, even these lifestyle factors impact the cell then. Now, most cancer predisposition genes are passed down in what we call an autosomal dominant pattern with incomplete penetrance. So that what that would mean is, let's say this dad carried a BRCA2 gene. No, he's not going to get ovarian cancer. He may get breast cancer, but he may also be healthy. Yet, unbeknownst to him, he can pass down this gene, this X, maybe it shouldn't be an X for the man, but this gene that's altered to 50% of his children, because half of them will get one copy of his Y and the other half will get the other copy, and half of his children will have this altered gene. And here's a mom affected with, let's say, BRCA. Purple is breast cancer, green is ovarian cancer. And these people with a dot, they actually have the gene, and that's what I mean by incomplete penetrance. They just haven't gotten the cancer. So, here's a patient who comes in asking about her family history. She has an aunt and a grandma. Her dad's healthy. And here's one, again, both parents are healthy, but another daughter gets it. So it's passed down to half of the children. Okay, so here, 1, 2, 3, 4, 5, 6 children. Actually, here, 4 of them carry the gene, just statistics, and then passed it down to another generation. I want us to differentiate, though, hereditary cancer genetic testing from what we call carrier screening. Many of you who may have been pregnant in recent decades, when you went into your OB visit, they did genetic screening. And that carrier screening, which is widely recommended by the American College of Obstetrics and Gynecology, tests for different types of genes. These are recessive conditions where you need it to be carried by both the mother and the father and will impact the baby's well-being and not necessarily doesn't really have specific implications for the mom who's sitting there. I've had many patients come in and tell me they don't need genetic testing done because they already had it done. And I trust them, but when I go through the medical records and history, what they're talking about is prenatal screening. And I think it's important for people to understand that difference so that if indeed they should have cancer genetic screening panels done because of their family history and other things that may impact their well-being, their doctors don't check it off as already done because they had prenatal carrier screening. So who should get genetic testing? Everyone with ovarian cancer, we can say that, but who else of your friends and community? Anyone who's had a cancer, most likely at a younger age. We recommend all childhood cancers get this germline testing. Anyone who's had multiple cancers in a single patient or in both organs, so both breasts, both kidneys, clearly both ovaries are a part of our disease, but someone who comes in and tells you that they've had multiple cancers should consider having to see if indeed they carry a cancer predisposition gene that is in their germline, a hereditary cancer gene that's been passed on. Again, when you think about multiple family members, unless there's any consanguinity in your family, you're really looking at each side of the family tree separately. So, your mom's side, your dad's side, multiple generations. Thanksgiving's coming up. It's always fun to put together a family tree and sort of get more information there, not just about cancer, but about other risks, diabetes, heart disease, etc. Unusual cancers, I should say uncommon is probably a better word, but things like male breast cancer, ureteral cancer. I had a patient come in and put that in her history. And I thought that, that made me think of Lynch syndromes because that is specific to there. There are certain birth defects associated with certain cancer syndromes. So again, part of the history, certain ancestries like Ashkenazi Jewish ancestry can be associated with an increased risk. It's always best when possible to start with someone who has a cancer, if that's possible, to make most sense of the information. But this information, as they say, an ounce of prevention. It's estimated that in 2021, there'll be over 500,000 US citizens diagnosed with breast, ovarian, pancreas, colon, and endometrial cancers. In that group of cancers, about 8% are hereditary, so it's 43,000 women who developed a potentially preventable cancer. In addition, there are over 4 million survivors of breast and ovarian cancer in the US. and only 14% of them have had their genetic testing. So there are many survivors out there. I see patients all the time who might have had a breast cancer 20 years ago, thought they were cured, sort of lightning wasn't going to strike twice. And they indeed present with ovarian cancer, having never had testing. But it's also a missed opportunity if someone does have one of these cancers later on for targeted therapies, for secondary cancer prevention, like I said, and of course, for cascade testing, which we'll talk about in a little bit, about the opportunity to speak to your family members and give them this potentially life-saving information. Which gets to the next point. It's estimated that of those folks who are unaffected by cancer, that 90% of those who carry things like a BRCA mutation don't even know about it until someone in their family gets cancer. Identifying a cancer gene gives you valuable health information for you and for your family. There's risk-reducing interventions, both medical and surgical, if you know you carry one of these genes. Increased screening for early detection, like breast MRI. For pancreas screening, we even recommend MRI and endoscopic ultrasound, prostate screening, etc., colon cancer screening, if indeed it's a Lynch syndrome gene. But there's family planning considerations. Both men and women would like at times to make themselves available of this. If you know you carry one of these genes, many individuals these days use assisted reproductive technologies to select embryos that do not carry a cancer-causing gene. Again, I think something that could be individualized with each patient, at their physician and their family. But of course, as you heard, there's great new breakthroughs that have transformed our treatments, things like PARP inhibitors and immunotherapies that really can extend survival and survivorship. And of course, if you find out you don't carry a cancer-causing gene, even though your sister or mom did, that is relief. But we need to act on this information once you have it. So just as we discussed with the COVID vaccines, the vaccine development, just like these cancer genetics, the tests have been remarkable. But it's really when you find out you have one of these genes to actually act on it. And in this conference, you may say it's surprising, but believe it or not, when one looks at populations, when folks find out the information, they may have some screening, but in the next 5 years, it goes down to only about 20% of people who continue to follow through. So I think, we're working with involving primary care doctors to also be involved in this to help remind patients who are healthy to try to avail themselves of early detection tests that are indicated. So as you've heard before, that for ovarian cancer patients, really 100% of the patients with invasive ovarian cancer, no matter what histology it is, whether it's a clear cell tumor or a serous tumor, should avail themselves of genetic testing, because almost 1 in 5 will carry a hereditary change that may have predisposed them to getting that ovarian cancer. There's a long list of genes that could do this, and we do recommend individuals have panel testing, which is the same cost as testing for just one gene. Again, even if you know your mom, let's say, carried a BRCA1 gene, you don't know what your dad may have carried. And so it's really important to still get a panel testing, even if you've identified a mutation in your family. Of those women with ovarian cancer who were found to have one of these genetic alterations, about 40% of them had no family history of cancer. So again, that is why we recommend that all women with invasive ovarian cancer undergo genetic testing. What I've been talking about today mostly really is what we call germline testing, the testing for just hereditary predisposition to cancer. That's typically done with a blood test or with a saliva sample. Can even be done with a pap smear, but I think most frequently now, especially with COVID, we're doing a lot more with saliva samples. But there's also somatic testing or tumor testing, which looks for the similar alterations in the tumor as well as others that can also direct therapy. And really, as we evolve our treatments for ovarian cancer, more and more both are necessary. We've said germline testing is important for everybody, irrespective of family history or tumor cell type. But the tumor testing I'm doing more and more on just about all my patients, because as they live longer, there are more and more treatments that could be possible. But especially if germline testing is negative, which will be the majority, right? 80% of folks aren't going to have one of these hereditary genes. So then testing the tumor is also very important. It can identify alterations that would allow access to maintenance therapies and to other treatments that might, again, really help extend survival. We've said before about PARP maintenance, immunotherapies for those that have microsatellite instability or high mutation burdens based on Lynch syndrome inheritance. And I think we're getting to a point where liquid biopsies, where we can look for shed DNA from tumor cells in the blood, may replace tumor tissue. So you don't necessarily need to go back if you have a recurrence and have a biopsy done. Sometimes liquid biopsies can take that place, and something, again, for you to discuss with your doctor. Germline testing is still important, even if you've already had tumor testing, but never had germline testing. You still should go ahead with this. It helps inform, and a lot of this is also in breast cancer. What are the surgical decisions? Would someone want to consider having bilateral mastectomies instead of one? Are there targeted therapies clearly that are important? But we gave the examples earlier of additional primaries, women who have been in remission for ovarian cancer for many years. We've seen them, of course, get diagnosed later with breast cancer or pancreatic cancer. So things that we can have increased surveillance. Imaging interpretation, you may have a CT scan and see something new. And is that a metastasis from your ovarian cancer, or is it related to a new cancer that you're actually at high risk for? So it helps really in all of the evaluation of your tumor at the time, of your status at the time. The tumor molecular profiling will actually miss 5 to 10% of the germline mutations due to the way the testing is done. So again, you don't want to miss out on that opportunity or the opportunity to discuss it with your family members. So I've mentioned cascade testing a few times. So what is cascade testing? It's really the extension of your genetic counseling and testing to blood relatives who might have the same gene predisposing them to cancer. So here's a patient who came to see me, 44 years old, her dad had prostate cancer, okay, and then, and onto breast cancer. Not, again, she was going to have her genetic testing, but in testing her, and we found out she carried a gene. Indeed, her grandma had died of breast cancer at age 55, but she had this cousin who she really didn't keep very close with, but who had breast cancer at 34. So it's, we now know that here, these two guys are at risk for cancer, and her siblings may also be at risk for cancer. So again, finding out one person has it allows us to give information to others to try to help them undergo those screenings and prevent cancer. So it allows the family members to personalize their own cancer treatments. If they've not already had the cancer testing themselves, you tell them, and if they undergo the genetic testing and are found to also carry one of these genes, they may have treatments available to them. Family members who test negative could avoid unnecessary screening, avoid risk-reducing surgeries. And we've seen this happen in my practice many times. The patient gets, years ago now when testing was just rolling out, patients who'd been scheduled for risk-reducing surgeries who were able to avoid that because they found that they were not at an increased risk based on at least an inherited BRCA mutation. Family members who test positive can really develop their own personalized clinical management plan to reduce their risk, make lifestyle changes, and make reproductive changes, as I mentioned earlier. So I encourage all of you, if you've had your testing, as things come up, really discuss this with your relatives. I didn't put in here, but I have a wonderful patient who's a nurse and has, I think now, identified 9 women in her pedigree, in her family, who are cancer-free, but were found to carry the same alteration, the same genetic alteration she inherited. So, remember, half of your first-degree relatives and a quarter of your second-degree relatives, meaning first-degree relatives are your sisters, brothers, children, and parents, and second degree or beyond that. Let them know. You really could have a huge impact and potentially even save their lives. I think I said, of individuals who have a pathogenic variant, meaning, they found out they carry one of these mutations, only about half to 3/4 share the result with someone in their family. More women do than men, but still it's really important for folks to be open enough if they can to discuss it. Less than half of the family members with whom the test results are shared actually get the genetic testing. And these days, with the opportunities to do telegenetics and have saliva testing, your words can really have a great impact. Again, it's important to try to get each person to reach out to the members in the family that they keep in touch with. Remind the guys that even though things like BRCA have been talked about as a breast ovarian cancer syndrome, they're just as likely as women to carry one of these genes. And the communication of these results is even lower amongst minority populations. So it's important for everybody to have this. You've probably all experienced telegenetics throughout this pandemic, and it's really been a boon for the dissemination of genetic information. There have been randomized trials before the pandemic showing that telegenetics versus in-person counseling really are about equivalent in terms of patient knowledge and satisfaction. But it's easier access, lower costs. You don't have to pay, at least in Los Angeles, between parking and driving and the price of gas. This has actually been very, very helpful for patients. It allows us to have a much further reach to underserved areas. And I've done some wonderful cascade testing platforms where a patient has notified 4, 5, 6 members across state lines. And we can set up a Zoom to do cascade testing with multiple family members and then mail them saliva kits, spit kits that are really just as reliable as blood to do the genetic testing and then follow up from there. Genetic testing, of course, we've said it's all ovarian cancer patients, but anyone ever, it should not be based on race. We know race is a social construct, and the prevalence of these cancer susceptibility genes is the same in Black and white populations. This was a large study done in breast cancer patients up here with looking at specific genes, but really large, like 25,000 white patients and almost 4,000 Black patients. And overall, there was no significant difference. About 5% in each group carried one of these genes. A smaller study has been done in ovarian cancer against smaller numbers, but same thing, no significant difference identified between Black and white patients. So we need equitable access to our genomic advances if we're going to be able to deliver equitable care and reduce disparities. And we have had significant under-testing in underrepresented minorities for many, many different reasons. But what this study showed is that African-American, Latinx, and Asian populations were 4 to 5 times less likely to undergo genetic testing than their white counterparts. Physicians were less likely to recommend testing, even adjusted for family history and risk. Patient populations were often less aware of the service, they didn't ask about it, and then less mutation testing. So I think some of the ideas to reduce disparities is to use computer-assisted ways to collect family history that are colorblind, to allow better patient navigation, and then implicit bias training for everybody to make greater access to the testing available. Genetic testing really can improve survival and survivorship. We know from Dr. Coleman's talk, and I think we all know as a community now, that it's over half of patients with ovarian cancer could be susceptible to PARP inhibition due to alterations in DNA repair genes, and that PARP maintenance therapy can significantly prolong survival when there is one of these alterations. It can also now, we've seen, be used to treat ovarian cancer recurrences and be as effective as chemotherapy. So having this important genetic information really can be a road to treatment and better life for you. And while I've really focused on those genes specifically, we know that the Lynch genes were less common for women with ovarian cancer, but those tumors who carry those alterations really do benefit enormously from immunotherapies. again, unfortunately, I think we'll hear Dr. Riccone in just a few minutes talk more about immunotherapies, but this is one group that really does show significant benefit. As we celebrate Ovarcome, our survivorship, I think ovarian cancer has significantly contributed to the survival and treatment of other patients with cancer as well. It's really a basis of the discoveries made from ovarian cancer patients, ovarian cancer beginning in the fallopian tube, the basic biology and the science that brought PARP inhibitors forward and have their FDA indications in ovarian cancer that we talked about. But based on that specific unique biology of what we called synthetic lethality, other studies were done, with pivotal trials being now announced for the role of PARP inhibitors in breast cancer, in prostate cancer, and in pancreatic cancer. And more we're seeing use of PARP inhibitors in other cancers, even sarcomas and things, where we see a BRCA type of molecular profile in those tumors as well. So we have lots to celebrate today, being here, being together, even in this virtual format, but we have forged ahead with courage and inspiration to bring these advances to a much larger community globally. So I'll say we will overcome this battle. Cancers, however, are still cancers during a pandemic. I believe research cures cancer, and we can only do that together as advocacy communities, participants on clinical trials, dedicated clinicians, scientists, nurses, genetic counselors, everyone who comes together to work with us. They're all an inspiration. And I want us to remember those in your life, but here are also some others. Ovarian cancer doesn't know whether you're Black, white, old, young, rich or poor. It strikes widely, and we need to have greater awareness. And I hope that some of the information today will help you in your fight. I'm happy to stop for a second, take a few questions if you'd like, but I appreciate your attention today.